Good morning, everybody. Thank you for joining us. This is Dr. Deb from Amarillo, MD. She's starting a new venture with the direct primary care space, and we're excited to hear more about it.
Thanks,
Morning,
John.
Dr. Deb.
Thank you for
You're
having
welcome.
me. I'm really excited to be here.
I guess let's just start. Tell us a little bit about you and where you are and what you're doing.
Sure, yeah. I have owned my own direct primary care practice for 8 years. I got out of the fee-for-service world when I was, disgruntled with not being able to take care of my patients the way I needed to. And, the pressure to just see more and more and more patients, less and less time. And I'm an out-of-the-box thinker, so it's pretty easy for me to jump out of the status quo and, operate in that space. It's not as easy for, everybody, but I have an entrepreneurial spirit already and enjoy a challenge. Most doctors like hard things, so this is it's a different kind of hard where we have more control over patient care.
Yeah, you get to take your medical license, what you've worked so hard for, and actually apply it in a way that you see it best fits the patients.
Yeah, absolutely. Yep.
Yeah. Mm-hmm. I've spoken with a few direct primary care physicians, and that's the common theme. Hey, I don't like the way things are going. Mm-hmm. How long have you been practicing direct primary care?
So 8 years in the DPC space and about 10 years before that. So having experience helps in family medicine, of course. I started out of my car doing house calls. That was a pretty fun story. I was like Dr. Quinn, medicine woman.
It's just you call and I'll show up and see you at home.
Yeah.
That's the way medicine was. I mean, we're talking years and years ago, right? Yeah. The community, the neighborhood doctor would, grandma's sick, phone the doctor, right?
Yeah. And the doctor answered and then came to the house. So we just, it's a little bit of a mixture of the good old days like that and technology. So, we have the virtual care where I can just jump on like a video like this with my patient and take care of them that way if it's appropriate. And of course, I have an office now. I didn't stay in my car for long, but, I just definitely believe in making sure things are financially feasible. And so I didn't want to invest in an office space without having patients to support that. So, I don't take debt. So I have no debt in my practice, which I'm really proud of. It's definitely been hard, but I'm really happy that I've done that. It draws a boundary that is actually very safe and keeps you from maybe growing too fast, which a lot of people will do that.
Okay. So maybe I want to kind of dive into that, the business model. Mm-hmm. So it's been 8 years since you've opened the doors, or at least kicked the insurance out, right? Uh-huh. How has it grown since then? So it was 8 years ago was you. Mm-hmm. I've saw on your website, it's more than just you now.
Mm-hmm. Yeah.
Can you tell me about that growth?
Sure. So at the beginning, I did everything. I had, just an EMR that was made by a DPC doctor for DPC doctors. And I had a mentor, of course. I really highly recommend people have a direct primary care mentor doctor to get started. And then I took $10,000 out of my 401k and I started it up. And so that kind of helped me get the LLC formed, which is professional LLC, and, learned a lot in that process, getting an EIN number, all of that I did on my own. And I enjoyed that. Not everybody does, but I enjoyed it. I got to make my logo or have somebody help me with that. And I really enjoyed that. And then eventually I did rent a space, and I just rented one office in this shared it's kind of like a Southwest vibe building. I wanted it to be relaxing. And this building, when I walked in, was just one of those, you take a big, exhale when you go in, and it feels very peaceful. And, it's got like big beams on the top that are wooden. So there's a lot of natural aspects of this building. So I rented a room in there. My landlord was really laid back. I mean, this was like a half a page lease that said, no animals and no candles. It was like $350 for the room. And so I started there afterwards, and I had my exam table in one corner of the room and a desk in the other. I kind of had, well, not in the corner, but I had my patients. They could sit across the desk from me, or we could go over. I think I had a couch too. So we had kind of 3 different spaces. We could do the exam table, the couch, and then a chair at the desk if we wanted. And so I just saw people there. I didn't have any assistants at first. I just wanted to make sure that I had enough patients to support whoever I hired. And so probably year 2 is probably when I hired my first assistant. And she was someone I already knew. I trained her, so she wasn't somebody who had medical experience. But I just needed some help with answering phones or faxing things off, just kind of admin things. So I still pretty much did all my own medical assisting at that point. I had like a little kit for rapid tests that I would just keep in my exam room. And so I'm looking at a kid's throat and I want a strep test. I just grab the swab their tonsils, and then the little point of care tests are really easy. So I just would run the test, and 5 minutes later have the answer. Same with flu, or COVID wasn't really a thing then, but we can do all of that point of care testing. And so I just did all of that myself till I needed help.
Yeah. So I just want to pull 2 things from what you said. First, you described a room, maybe like a living room, a very comfortable office, where you see patients. And so I'm like, oh, okay. Maybe a therapist, a psychologist would have a room like this. Every time I go to the doctor, it's very sterile looking, very clean looking. And the environment, though maybe it sends a sense of reassurance that the place is clean,
right.
It doesn't necessarily give me the sense of comfort or willingness to open up. And, you sit on the exam table with the paper, and it's like, as soon as you hear that paper, you forget any question you may have had. You forget, so, and then it's like nurse comes in or assistant comes in, physician comes in, and it's like, I guess I don't remember why I'm here other than this is my checkup, or, I feel sick, and they're rushed anyway. So you don't even get the chance to really question. So the couch scenario, or the sitting in a chair across the desk with somebody, kind of like what we're doing virtually, really, really allows you to think. Practicing, let's just call it traditional medicine. When you took insurance, you were a family practice.
I was. I didn't own my own practice.
Primary?
Then I worked for a corporation that took insurance.
Could you kind of give me how many patients you were asked or you were required to see at that practice, and then what you do now, or what is expected now?
Yeah, I mean, so when I worked in the regular kind of corporate world, which is just a word for I was employed. I saw patients. I mean, there were sometimes I would see 40 patients a day. And it was in an urgent care occupational medicine setting. And I was a medical director of 2 of those clinics at one point, or at different points. So I supervised other doctors who were also seeing that many patients. And, it was fast paced. I enjoyed aspects of it. I enjoyed doing stitches on somebody's face or things like that, but you never really had time to do them. So as you're doing the sutures, you're thinking, oh gosh, how many are stacking up right now? Or who's in their room fuming right now because I'm half an hour late, while you're sewing this, laceration all the way down. There were good aspects to it. And then the worst aspect was that. Now, I'll tell you kind of one of the straws that broke the camel's back there was they rolled out this star system. And this star system, because I was the director, so I saw it first. This email pops in. Actually, I didn't see it first. The email pops in for all the providers. So we're all seeing it at the same time. I actually didn't have any lead time, didn't know it was coming. And the star system gave one of my doctors a 2 star out of 5 was her grade.
Oh.
And if you know
from administration.
Yeah. If you know anything about
Oh,
doctors, I mean,
gosh.
we're high achieving people. We want to get 100 on the test. We're driven, And
Mhm.
so for her to be working so hard in a job that she probably didn't love, entirely, wasn't glamorous, didn't pay, better than something else she could have gotten. She quit that day. And
Yeah.
I called my two bosses. Um, they were both physicians. They didn't really make up the system. They just happened to be my bosses. And I said, I want to hear what these stars are. And the stars were related to really things like self-referral. So in our system, we had a PT department and then some specialists, not all of them. So they made these parameters like making sure all musculoskeletal injuries went to PT, every single one. So if there wasn't a referral to PT, then you lost points as the doctor. And of course, that's a self referral. And the musculoskeletal case is a contusion, which is just fancy for bruise, is a musculoskeletal condition. And so if we didn't refer someone for a bruise to our PT department, then stars were taken away or points were taken off. And then another one was if we referred out before 14 days, then we were also docked points. Well, we were occupational medicine and an urgent care. So people would come with like metal in their eye from grinding down something. And you absolutely have to go see the ophthalmologist to get that out the same day. And so that would be a referral before 14 days. And so that would be, I know, that's exactly what I did.
The system is stacked against just against it.
Yeah.
I mean, against the standard care.
Yeah. I mean, so you couldn't win as a physician. And I was really upset about it because they didn't tell me about it ahead of time. And, then my physician quit and she was really good and, it was going well. And now all of a sudden we're down a doctor because they were foolish, basically. So.
And that's what I was going to ask you, and not necessarily from your perspective, because maybe you didn't necessarily oversee her in every examination, this physician that quit that day, how she performed with her patients. I would assume
it wasn't there.
That would be No,
it wasn't in there at all. All 5 of the parameters they were using were related to income. And that really was upsetting because, what matters is how well are we doing our job. So it didn't matter that I could sew up a laceration on the face and almost like a plastic surgeon. I mean, that's really something you're proud of. If you can do a multi-layer suture or something like that, it's a big accomplishment for a family medicine physician. And we love doing those things. But none of that was ever, whether your patient got well or you handled them well in the clinic, none of that was related to the stars. It was all related to, did you refer out of our system or did you not refer in for a bruise? And the categories were just, not well thought out at all. And then the other straw that broke the camel's back in that scenario was a guy came in for his DOT physical, which is what truckers will do to make sure they can drive safely. So we did a lot of those because we were occupational medicine. So the guy tells me that he stops breathing in his sleep. And so I obviously am going to get a sleep study because that's, self-reported apnea. Now, he wasn't obese and didn't have like the neck circumference of over 17 that a lot of people do, because that would be kind of one of the screenings. He wasn't the typical sleep apnea patient, but he was quite certain that he would stop breathing when he sleeps. So his company calls up and they are livid that I have ordered this sleep study on this patient. And of course, patient confidentiality, I can't say on the phone, well, he said he stops breathing in his sleep, because I'm bound to make sure that what happens in that room is between me and the patient, not their job. It's really sticky to start talking to somebody's employer about. But, they're paying for the DOT, so they think that they have privy to all the information. So they're on the phone with me, just livid about this. And so I'm trying to, navigate and really talk to them about how this could save his life, or maybe 30 other people if he fell asleep at the wheel, or maybe their truck would be saved. I was trying to find their motivation. If it's money, hey, I can save you a truck. If it's we care about our employee, hey, I can save your employee. If we care about public safety, gosh, I can save 30 people from death right now by getting him a sleep study. None of those things. I didn't care. They did not care about any of it. And so then they, are off the phone, hang up on me, and they're calling my boss. Well, this company is a national account for my company that I work for. So they've contracted to do all these DOT exams for their drivers. And so there's a lot of pressure to please them. And, they were very unhappy about this. And so all they have to say is, well, we're going to find someone else to do our DOT exams. And there you go. It could be hundreds of thousands of dollars around the nation that are gone because I wanted a sleep study for this driver. And in fact, am bound by my training to get it. And not to mention just public safety. That's what a DOT physical is I'm standing in between a dangerous driver and the public, making sure that driver treats their sleep apnea so that they don't hurt anybody. So the end of the story is they actually sent the guy back through my clinic and had the doctor that had quit, had the other doctor see him. And he just neglected to say, I quit breathing in my sleep.
Oh.
And since he didn't have a big neck or, any of that, she wasn't triggered to do it. And I had no idea he was coming back. So I find out after the fact that he got his DOT card from the physician that I supervised because he didn't trigger any further testing. So I don't know if that was, I kind of thought that probably my company just said, hey, just send him back through and tell him not to say that. I'm not sure what happened, but that was one of the last things when I said, I'm not going to be part of this. I'm going to make sure that I can protect the public and do my job correctly. And, the ridiculous thing about that too is that sleep studies shouldn't be that big of a deal, but they were, like $5,000 inpatient if you go to a sleep study center, which is what kind of we did now. And back then I could have done this if I'd had control of it. But when I opened my practice, I realized, I can rent a sleep study machine for someone to take home. I can rent it from the manufacturer and send it home with them, and they sleep with it one night, and I know what kind of sleep apnea they have or if they have it. And then I can start them on CPAP. So I was just charging like $100 to do that for my patients, after when I figured out to do that. So now the cool thing about having my own practice is if I have a pain point, I can fix it. And I love, I eat problems for breakfast. I just love fixing problems. So if we need something, we need an EKG, we need an ultrasound, I can find how to fix that and do it for our patients.
So, you even when you were there, you were skipping protocol, or at least the written protocol, to say, we refer to the sleep environment, the sleep study place, and it will bill the insurance or the employer's insurance X number of dollars. That's just what it is.
I really was only just denying the card or giving them a short-term card. In that case, I wasn't actually writing a referral, and that's kind of separate from the work comp part. But they were responsible then for going and getting a sleep study. So we didn't even really help them get a sleep study. We just had to say, well, here's a 2-week card or here's a 3-month card, and you need to get this sleep study before that runs out. And then they kind of had to do that. So we only billed for the DOT.
Okay.
Yeah.
Okay. Yeah. Awesome. So that was then increased schedule, a lot of patients in, a lot of patients out. The STAR system was one of many things that just weighed upon you to leave. How long after you think you got that email with the STAR system that you're brave enough and courageous enough to leave?
Well, So I was directing that clinic, working for 4 days a week as the director, long days, like 10-hour days, or usually more, but technically 10 hours a day. And then, so I said, hey, I'd like to go down to 3 days a week. I had a couple kids at that point, 3, I think. And I wanted to work a little bit less and have a little less stress because it was stressful. So they said, well, you can't be medical director if you work 3 days a week. And I said, that's okay. I don't need to be medical director. And then they said, well, you can be medical director and work 3 days a week. So it turns out they needed me. So eventually I transferred clinics to one closer to my home where I could bike to work and kind of get a little bit better balance. But I didn't actually know about DPC then. So I just was kind of hanging on, trying to figure out what to do. So it was still probably maybe 2 years. I transferred to Amarillo and worked in their office in Amarillo, and was doing just PRN shifts, and that started to not be really fun. I was supervising the mid-levels, the PA, who was kind of the director of the clinic, but I was the supervisor because they need a supervisor. And one of my bosses changed abruptly one day, and I came in, and myself and then the other female provider that we had on staff, both of us, our shifts were just completely taken off the schedule. And I was like, what? And I had this huge stack of papers I'm supposed to sign as the clinic supervisor. And I was pretty upset. I technically was PRN status, but I was really regular and I was supervising. And I was really experienced. And then she was also caught off guard. And I don't know if it was, intentional that it was both the female providers, but we just came in and all of a sudden, no notice, we had no shifts. So I called the new boss's boss, who I had been in, I'd been to some corporate events and had met some of those. And I called him and I said, I have a stack of papers to sign and I've lost all my shifts abruptly and I'm pretty unhappy about that. And I said, I want a few months to work this out. Because I was definitely not going to stay after that. But I wanted some lead time to make sure I had what I needed. And so he agreed, yeah, absolutely. We'll get your shifts back on. And so I had a couple months there. And in that, I think it was in that period of time, I found an article, and I think it was by Dr. Brian Forrest. And it was him describing how he was doing this membership model. And I think he called it direct primary care. I can't remember now, but I found an article and I was stunned and I was like, oh, okay. So then I go on, and look online and YouTube, and I'm trying to figure out, well, do I have to have a lot of money to do this, or could I just do it? And I'm really creative and very tenacious. So that together helps me innovate. And so I got on and found some of Josh Umber's videos of him just kind of talking to a little crowd here or there about what he did. And I think it was him that said, you don't have to go into debt for this. You can start really simply. And so I kind of got an idea of how I could start. And so that was 8 years ago. And so that's, in contrast now to, I have an hour and a half with each new patient. And all of my providers do. And so we grew from that one room where I was seeing everybody to a little front desk area and one room, and then 2 rooms and a little front desk area, and then 3 exam rooms and other providers. So now we have a nurse practitioner who's a certified nurse midwife, another couple of doctors, and we're having a great time. It's definitely never easy. I wouldn't tell someone going into direct primary care that it's easy, because it's certainly not easy to own your own practice, but it's rewarding, and I would never go back. Never. Not for millions of dollars. There's no way I would ever trade what I have now. So
100% autonomy. You control with your patients their care.
Yeah.
You even mentioned EMR. Like
Mm-hmm.
when I'm talking with people, it not only is it my day is demanding, but my documentation,
Mm-hmm.
what I'm required to document. And this is a lot of new physicians, and I think it gets easier the more experienced you are.
Mm-hmm.
You can balance your workload better. But I mean, talk about that.
Oh yeah, I mean,
you get to chart. Who tells you what to chart?
No one. I mean, I chart what I need to chart, and it's shocking because I mean, all the doctors know, all the providers know that when you request records like from the ER or anywhere, you're getting, I mean, 4 times the number of pages that are really needed to document that encounter. So my documentation would be, on a SOAP note, let's say, so the S is subjective, what the patient says. That would be sore throat, maybe fever. It'd be 2 words. And then it might be, we do a little bit of review of systems, no cough, or no nasal symptoms. And that would be it. I mean, just very few words. And then objective is what we observe on the patient. So our physical exam. So maybe a temperature. You could do a full set of vital signs, but you don't even have to. And then the A is their assessment. And so you could do tests before that, do a rapid test, get a positive strep, or it's negative, but you're going to treat anyway because the tests aren't perfect and you have enough clinical findings. So the assessment would be pharyngitis or strep pharyngitis. And then the plan, amoxicillin, or I'm learning things like you can use a 3-day Z-Pack for strep, which, never have time to look up anything in the other world. So that's the other piece of this is doctors are practicing archaically now because they've never had time to look up other ways to do things. And so the other day, I just found, a 3-day Z-Pack can be one of the most effective strep treatments. Well, a 3-day Z-Pack at 500 for an adult, 500 milligrams for 3 days, that's a lot different than 10 days of amoxicillin. And 10 days versus 3 means probably the patient's going to finish the whole course of antibiotic easily, and they never finish 10 days. It's just, they feel better after about 24 hours, and it's kind of just ridiculous that they keep taking it, but that's the recommended amount of time. And, so looking for ways to make things better, I'm doing it all the time. And there are studies, and they're good studies on these, but doctors don't, I think most would be embarrassed to say that they don't look things up. They either work 24/7 because they look things up in the fee-for-service world, or they just don't look them up because it takes too much time. And you already know that amoxicillin works. So give it for 10 days, move on to the next one because you only have 5 minutes in the fee-for-service world. So our documentation, it's like nothing. And now we also even have AI tools that we're using for that.
You mentioned you're part of a kind of a new organization, or you're heading up a new organization called Direct Care Nation.
Mm-hmm.
What's that?
So, now I'm really passionate about bringing in other physicians to this model. When I first started, it was more like an experiment, right? To see, can this work? And, I always paid myself, but not very well to begin with. It was, I didn't have very many patients. So I was always supplementing my income with doing other things. And so I didn't want to start, talking much about it when I hadn't really succeeded in it yet. So, 8 years in, I feel like I have the experience now to say, I definitely know this works. I definitely think it's the way medicine should go, at least, in many regards. And so I started Direct Care Nation to help get those doctors out of the fee-for-service world into direct primary care. And so it'll have several functions, but that'll be the primary one, is getting those providers. And, we'll work with PAs and nurse practitioners as well. But we're really looking for those doctors that can head up clinics And, I want to really make it specific to that person. So many of the doctors coming out of fee-for-service, they're very gun shy about employment. And they don't want to jump back into an employment relationship. But then also they may not be very entrepreneurial, and they would have a really hard time running their own practice. So I think Direct Care Nation exists so that those who are not highly entrepreneurial, but very motivated to get out of the fee-for-service system, have a place to be, have a place to go. And you could think of it as a mentorship of sorts, but also a place where we can help with kind of the back office things, the accounting, the legal things, the systems, the technology, all the things that are not specifically doctor related, but are necessary to run a practice. So
that's awesome. Yeah. Making a clear path, way forward. And we're talking primary care.
Mm-hmm. Yes, this is all primary care.
So for primary care, way forward for them to kind of set back, go back into the olden days of doctors taking care of people the way that it was intended. Right. Awesome. Yeah. That's great. And I think, between what we're doing at Common Care, I think there might be some collaboration availability. So
for sure. We need people who are in the employer space to make people aware of what we're doing. And then, for me, Direct Care Nation is the nation. So there's not a state that's too far. I have doctors and PAs and nurse practitioners. They call me from all over the nation, say, hey, do you help PAs? Absolutely. We help PAs. And we'll, if you happen to, Sean, get an employer group that's really interested in DPC and they have, 200 or 300 employees, they're ready to sign up. That's enough for us to drop a clinic there. And so we could definitely collaborate. And if you're selling a product that includes DPC, or you want it to include DPC, then, you can call me and we'll see about finding a provider there. I may already have an interested provider. But really, I just want doctors to have a safe place to work is really where I'm at. I'm not really money driven, money motivated. So that's not at the top. I would say our values, or maybe our tagline in Direct Care Nation, is patients first, providers next, and profit last. It doesn't mean we won't make profit. We should really do well if we're delivering what our patients need. And so it does take some business savvy to do that. But it's definitely doable. And then on the specialist side, I think Direct Care Nation is also going to have a space for specialists too. This is certainly not an exclusive space for just primary care physicians. There's room for everybody here. And I think Direct Care Nation will be a place that, many people can come to find a place to kind of plug in,
So for that specialty care physician who would like to mimic a DPC, what does that look like? Or do you know?
I don't yet. There are some specialty physicians doing DPC. They're usually doing it in a crowded area in a large city, because there are more patients there. I don't know if they're doing a membership model because, unless it's a patient that regularly needs that specific specialty, then maybe the membership model doesn't work as well. But maybe they're just doing cash pricing, and they're being really forthright about that and encouraging people to come and not use their insurance. A lot of things look like the sleep study situation, where I said I can send a patient home with a sleep study for $100. And if they went to a sleep center, they'd get the same information and probably less customer care afterwards for like $5,000 using insurance, So it's just unbelievable. And people don't know how easy it is. But doctors, once they get into the space and, hear this, you can do $100 sleep study and find out that you have sleep apnea. Or you can do a $5,000 study and find out that you have sleep apnea. And the auto CPAPs that are for treatment, they also adjust themselves. So one of the frustrations with, after I would get the sleep study is I would send a prescription to one of the durable medical equipment places, and the patient would go there, buy the machine, whether they use their insurance or cash. They'd buy the machine, they'd send them home with it, and then no follow-up at all. And, we know that a minority of patients would be able to succeed with their CPAP with that. So I just started then buying CPAPs at wholesale and then selling them to my patients and making sure that we're setting them up correctly. And then, having them check in 3 days later, and we can adjust it remotely. So if they live far away, we can just hit some buttons and adjust their usage based on, or their pressures based on their usage. So, we're very remote friendly, and we cost less and we do better. I guess that could be a tagline too.
Where's the downside? Right? What's bad about that? It all sounds positive.
Yeah, and so say that sleep doctor that does that, and they open their clinic and they just focus on cash pay sleep studies and setting people up with CPAP and really giving them the care they need to use it correctly. In a big city, that works. It really works. Or if maybe it's ortho and they're gonna do X-rays for cash rate and visits for cash rate, and they do a good job marketing themselves so that people know about it, then absolutely ortho is going to be busy enough in most cities to do their own X-rays, do their own MRIs, maybe CT scans even. Radiologists can open imaging centers and definitely easily beat prices that people are paying with their insurance, and without all the, we need a pre-authorization. And, and now this CT scan that was going to rule out something really acute is now delayed by 2 weeks because, the insurance is being difficult. It's really a delay in care. And that's what's unacceptable to me about the insurance model is they have no way of knowing whether what I write is legitimate or not. And they should go on, it's probably legitimate, but instead they err on the side of, let's see how many times we can say no, or how many reasons we can give why we said no. And if you think about the model, that's how insurance makes more money. So if profit is your number one, which unfortunately it is in the insurance space most of the time, then people are they're suffering and they're getting a delay in care because someone has a profit first mentality. And that's just not fair. And patients deserve better. I want to make a place where my mom can go and not get, ripped off. And I treat my patients like my family. So I would say, if I want my mom to have a safe place to go as a patient, then that's true about every patient I have. And so we try to set them up. So there's definitely a space for specialties. And I think in, Direct Care Nation is going to be a space where we can really kind of pilot some of those projects around the nation and see what we can come up with.
Well, it sounds like you're pioneering a lot of things, right? Mm-hmm. 8 years ago, DPC wasn't well known, and there wasn't much about it. Mm-hmm. It's when you started, and I'm sure others have around the same time we're doing the same thing. Mm-hmm. But now it is more of a nation. It is more. Mm-hmm. There's a collective group. There's a lot of support, mm-hmm. and you're pioneering some of that support. Mm-hmm. I think that's awesome.
Yeah, I really enjoy
that's great.
It. Yeah, I'm really excited about it and really love making a safe space for doctors. So.
And you talk about wait time. If I get a sports injury, mm-hmm. I first need to go to my primary care provider under the traditional insurance model. He then refers me to the specialist, mm-hmm. Whether it's therapy or whether it's mm-hmm. to get an X-ray. Typically, I'm subject to that wait time, mm-hmm. and that could be anywhere from 3 weeks to 3 months, yeah. maybe more, depending on the system, right? And mm-hmm. it's all internal referrals. Mm-hmm. Well, at least through my employer, it was mm-hmm. right, all internal referrals.
Yeah.
And shoot, I mean, a sprain on a joint, a finger, an ankle, or something can either self heal or the pain can go away in that time. And now you're saying, oh yeah, no, it's not broken. They took an X-ray when you show up. No, it's not broken. You sprained it. Ice, Advil, whatever is gonna help you. But yeah, it did help me 3 weeks ago or 3 months ago.
Exactly.
I guess I'm just playing the game, and I'm sitting in your office because I was told to.
Yeah.
And that's one, that's not the right mentality for the patient. The patient should be able to own and take care of themselves and have the ability to through access.
Yeah.
And that's what DPC is. It's that access. Sure, maybe your schedule is busy tomorrow, and I got injured tonight.
No,
I can access you.
Yeah.
Sure, but I could access you tonight. I could through messaging, either you or one of the other providers at your clinic. Like, actually, Sean, you messed up. You do need to go to the emergency room. Yeah. That's serious. Yeah. Or no, please, manage your pain in this way, or manage your,
I have
your symptoms in this way.
Story I can tell you that exact scenario. Please. Yeah. So I had a patient just a few weeks ago who rolled his ankle really badly playing basketball, or at least he thought it was a rolled ankle. And so he lets me know in the evening, hey, I've hurt myself, pretty badly, and I'm in a lot of pain. And he was kind of panicked and in extreme pain. So he drives himself to the ER, or somebody drives him to the ER. And I text him back and say, hey, if you're not at the ER yet, you can absolutely ice, elevate, take some over the counters, and we'll take a good look at this in the morning. And he was just in so much pain and was already there that he was like, no, I'm just going to do this. So he's in the waiting room, and he goes back to triage, which is like where you get your vital signs taken. He gets his vital signs taken, goes back to the waiting room. He's cash pay also. Goes back to the waiting room. Then a little while, I don't know how long, probably a long time, they come back and get him for an X-ray. Nobody's seen him. No provider has seen him at this point. Goes to X-ray.
Triage, waiting room.
Yep.
Potentially hours, X-ray, and now someone's saying, let's go X-ray.
And then he goes to X-ray and he goes back to the waiting room. And then the next thing is somebody brings him out a ACE bandage and one hydrocodone and no crutches and no splint, no boot, and says, it's not fractured. You're free to go. So he hobbles out of there on this foot and is just in extreme pain. They didn't address it, and no one saw him. No one touched his ankle. He was not examined by a provider.
Right.
Yeah, and this is true. So I see him the next day, and he's still in a lot of pain. I pull up the X-ray from the hospital, and I send it for a second opinion real quick online. This is where technology is just so great, is we can just shoot that over to a radiologist, and it's like $10. Literally.
Yeah. You have a colleague, that you trusted that you send it to.
Well, yeah. I mean, this is a company actually that does this.
Oh,
yeah.
Is it?
And this is $10 read. And so they look at it and they go, you know what? You need some different views of this. There may be a fracture here that's potentially serious. So I send him over to our ortho down the street where we send our patients for X-rays. He pays $50 cash for that X-ray. And they know us and they know our patients. We send them with a referral. We kind of fax it over beforehand and they walk in and get it done. So he gets that done, brings it back. We send it back to the radiologist and they say, yep, that's a surgical fracture. He should not be putting weight on that. He should have that casted. He should see ortho and consider surgery because that doesn't heal very easily. And so sure enough, he had gone to the ER. He had not been seen. The wrong views had been ordered because an ankle view was ordered instead of a foot. The radiologist that originally read it missed the fracture that the second radiologist called out, got the right views, and we could see it clearly. But that, there was so much wrong with that scenario. And now obviously I want to open my own ER there's freestanding ERs and people are doing well with these. But it's insane. So my patients usually use us for the ER if their life or their limb are not threatened. And by limb, you can break a limb and not be life threatened. As long as the limb has blood flow, it's not going anywhere, and we can do the x-rays. And so, we, of course, he's going home from the x-ray. And this is actually an employee of mine. So I said, hey, since they didn't give you crutches and a boot, go by the clinic and get that and make sure you stay off of it tonight. And so he did, but we would have easily met a patient over there and just seen them at the clinic and, did the boot. We're getting big enough now where I think even having after hours clinic would be starting to kind of roll through. And, the more people that we serve, the better we can do that. But we take calls after hours and, really he wasn't better off after he went to the ER. He would have been better off seeing us and then getting the right x-rays. And so, but yeah, it was bizarre. He wasn't seen. And we started waiting to see what his bill looks like, which I guarantee you will be thousands of dollars. And so here's the sad part.
Thousands of dollars to sit in the waiting room.
Yeah.
Right.
Yeah.
Probably less than 20 minutes of actual, right. We're talking triage.
Yeah.
Radiation tech takes him back, lays on the table, gets the x-rays, back out. Hours of sitting in the waiting room. Yeah. That'll be interesting to see what that is.
I mean, and here's the sad part is, right away, and this is a really good point to bring up about doctors and providers in this system. So a PA had signed off on that report. And this really could have happened with anybody. I'm not sure why he wasn't seen or if they were just crazy busy, but, I don't want to really call out that provider or that radiologist. The radiologist is a doctor and the PA is a provider who should have seen the patient. That's all true. But really the system they are in is impossible. It is so stressful and so impossible. And I would hate to add stress to that because I'm going to assume that they're in a position, hospitals have doctors sign these contracts that say they're an indemnity clause, which is short for we can foul up the entire system around you and not give you people to do the right things, not give you enough staff, put too many patients for you to see, and we're not liable. That's an indemnity.
As a system.
Yeah. So the hospital owns the system. Doctors can't even own a hospital. The hospital execs or whoever owns it is owning it and they're staffing it and they are in charge of the system. And so if they choose to not staff that ER and that PA feels like this is a safe bet to do this with this patient, I mean, maybe they're just, they're doing their best and they've got, a heart attack patient in room 1 and they've got a stroke patient in room 2. And frankly, the ankle's not that important when you're trying to save somebody's life, So all of a sudden that ankle becomes way down on the list. And chances are that PA was in that situation. And that's true because I know of some other stories of doctors who have been working in the ER and nurses too. The work in the ER and someone comes in having a heart attack, which we're actually really good at treating and saving people who are having active heart attacks now in medicine. And that's kind of where Western medicine thrives, is these really abnormal situations where we can intervene. So a lot of times those patients go straight to the cath lab, they get a stent, and hooray, they're saved. Well, this guy goes into cardiac arrest, and the doctors sit at the head of the bed, and she's running a code. Well, all the people there, the staff, this was a rural hospital, not ours. You could argue that ours is too, because we're Amarillo, Texas, but a really rural hospital about an hour away. And the staff didn't know how to run a code. And so it's impossible to run a code at the head of the bed and then also do the code. It's a really very precise, quick, effective, active process. And so this doctor's having to actually teach them how to run the code while she's running the code. Well, the guy dies. And she decides, I can't do another shift in that ER because it's unsafe. So now that hospital has one less good doctor to run the codes. So now it's going to be another doctor who may not be very good, probably is, but it doesn't matter what the doctor does. If the team can't run the code, then it's useless. So those hospitals basically say, if that happens and you get sued, it's not our fault. And the thing is, if anybody gets sued, it's always the doctor, always. Because people think doctors have a lot of money and they think they are the ones with the power to change it. And I'm not saying that's, there's never a right lawsuit, but usually it's deserved by others. And the doctor is the victim in between as well. And there was a nurse practitioner who, she was actually a nurse in an ER, and she was in a pod all by herself. And a pod is supposed to be a whole team of people. She said they wheeled a guy into a room who had been short of breath in the ER for 6 hours. This was in a bigger ER in one of ours. Wheels him in, and he's short of breath. He'd been short of breath. She walks in, and the guy's wife is there, and he's in the chair, and he's kind of down like this. His wife thinks he's taking a nap. He's not breathing. He's in cardiac arrest. So the nurse takes him, quickly out of his chair onto the floor, and she hits the button for code blue, where the team is supposed to respond and run a code, right? Nobody comes. So she's got this guy in cardiac arrest on the floor doing CPR manually with no one else to run the code. Yeah. So traumatic. He dies, of course. He probably had a heart attack or a blood clot or, who knows. And I don't know how long he had been in cardiac arrest. But those are horrifying situations, not only for the patient and their family, but for that nurse. I mean, she's traumatized after that. And that happens over and over in our ERs. And, nobody knows this is happening because you don't need an ER very often, right? So if you don't need an ER very often, you only need them when you need them. And then you have a bad experience and it's just a one-time thing. Or you're the widow of the guy who died in the ER and you're grieving and you don't even think to question if something could have been done better, which is probably good for some of the medical people, because if they think about it, the people they're going to blame are the medical people, and all the while the system is run by, others who put profit first, and then the doctors, the nurses, the good people that you meet in a hospital, which there's so many good people. They're the cogs in the wheel, and they are literally being used as pawns in this system to make others money. And, doctors can't own hospitals. So that's one of the legislations we need to change, because we see it differently by and large. And, even if, say, there was a doctor who was profit first, they would at least know how to staff an ER, and make sure that there was a code team that knew what they were doing. So those are the scary stories people don't like to hear, because it makes you feel insecure about walking into the ER when you really need them. But if we don't get busy fixing this, that's going to be every single ER in the US, because the CEO of Walgreens or Walmart or any of these other, companies that are huge and are thinking, oh, well, we should get into primary care. I have a message. It's not easy, and it's not easy money. So you need to let the doctors back in. And we need to take this back. And then I have for doctors, hey, don't just go quietly into the night and leave medicine. People in the US are counting on us to step up and say, this isn't right, and we're going to fix it. And we really are the people who do have power to fix it, because we know those stories and we know exactly what went wrong, while everybody else can just kind of only guess. And we know the nuances of all that stuff. So, I'm kind of rallying the troops, per se, with Direct Care Nation is, come on, guys, we can do this. We're smart people, and we can work together, and we can get all the right people together and do something great.
That's a powerful message. Yeah. Thank you. Yeah. And thank you for your time.
Sure.
We talked about a lot of things today, and I think what you're doing right in the Amarillo and surrounding areas, I think that's where this needs to start, right? You need to start in the communities, start start local, and then you could branch out and have a greater effect. And your message that you just shared, that should be inspiring, right? That should be a message to wake up and say, yeah, we have the potential to make a change. Let's do it.
Yeah.
Thank you.
Yeah. You're welcome.